Welcome everybody to Grand Rounds. Delighted to have you all here and join me in welcoming Dr. Grant Mitchell, who's our chair for the Department of Psychiatry and Behavioral Sciences here at Beth Israel, which, as you probably know, includes one of the largest opioid treatment programs in the country and has an amazing history in the opioid treatment world. Dr. Mitchell was previously a vice chair for clinical services at Columbia and has had leading roles in the Westchester County Department of Behavioral Health. He's really a pleasure for us to work with, and speaking today around primary care and mental health, which is a particular interest of mine as a primary care doctor. So we are really excited to hear what he has to say. Please join me in welcoming Dr. Mitchell.
Thank you, Dr. Weissman, and thank you for the invitation to join you today. This is a topic that is near and dear. In a somewhat shameless plug, I'm showing the cover of my book, which actually was written almost 20 years ago now, more than 20 years ago. Around the issue of primary care and mental health integration. I will tell you that when we published the book over 20 years ago, integration made sense to people when you talked about it. Bringing mental health and primary care together made sense. But most of us at the time did not actually believe we would see it to the extent that we're seeing it now and over the last decade. Where the models around integrated care have really taken off. There's a lot of data to support those models. So it's been very gratifying to see that while this was just sort of a bit of a dream back then, that it's actually grown. And as you know, we have a number of integrated models of care here at Mount Sinai Health System. I'm just going to mention one of them sort of towards the end if people want to get some additional information. Just to start, it's a little blurry, but just so that we're all aware of the terminology, a lot of different terms are used to describe integrated care. Integrated care is sometimes called coordinated care, collaborative care, shared care. It goes under patient-centered care. It goes under a lot of names. And during the presentation, I may use them interchangeably, but I'm talking about integration of primary care and behavioral health, regardless of which term is being used. So just to start off with kind of why this is important, and I'm sure you're aware of this, but just to put some data around it, we know that the number of visits or the percentage of visits to primary care that are actually related to mental health are quite significant. You can see here in that 45 to 59 age group, almost a third of visits in primary care are mental health related. And that continues pretty much through the rest of one's adult life into geriatrics, and really starts to pick up at age 25. So really throughout most of the adult lifespan, you're talking about a significant number of visits that are going to be related to mental health, whether you want them to, like mental health or not. So we always feel like it's important to know kind of how to look at those presentations and how to treat those patients. So you're also, I'm sure, aware of the fact that in every case, in every single one of these sort of common medical problems, from high blood pressure to asthma, having a mental illness means significantly higher rates of all of these medical issues. So we know that those comorbidities are quite significant. And in some cases, when you look at asthma, for example, you're not talking about a little increase, you're talking about a 50% increase. So it's obviously very common in both our office-based and hospitalized patients as well. And I'm just going to stop for a second on the smoking. because it just blows me away that even though smoking is down across the United States, people with serious mental illness make up 6% of the population and are smoking 44% of the cigarettes. So to please remember, this is such an incredible way for us to have an impact on overall morbidity and mortality in patients with mental illness just by focusing on smoking. So of course, it's the, again, looking at the interface between mental health, substance abuse, and all of these common medical conditions. You can see very high rates of comorbidity. And the question, of course, always being, which direction is it? Does someone have a mental health, a serious mental illness or substance use? And then, of course, there's a higher risk of developing medical issues. And of course, the reverse is true as well, that having a significant medical issue can cause mental health. So it's obviously both ways, but it's very significant, the impact of each on the other. So here, just looking at the impact of behavioral health conditions on primary care visits. So I'm going to focus first just quickly on the red line. So the red line are basically adults that see primary care practitioners. And this group has no behavioral health issues. So typically about 50% of the patients are having one or more primary care visits per year. And then as you get to 3 or more, it drops to below 30%. And of course, 10 or more, there's still a group of about 7 or 8% that are having 10 or more PCP visits per year. So that's people who have no behavioral health issue. When you move to the purple line, you see the impact of having a behavioral health issue on primary care visits. You can see this huge increase from under 50% to almost 75% of patients with a behavioral health illness will have at least one primary care visit. And the number is almost double for 3+ and even 10+. So a clear impact on relationship between having a behavioral health issue and the number of primary care visits you have in a year. Same thing holds true for admissions for those of you doing inpatient work as well. Again, the red line represents adults with no mental health issues. About 7% will have one hospitalization during the year for any reason. And then it pretty much drops off to almost 0 for 3 or more inpatient stays. But then when you again look at the purple line, which are individuals who have a behavioral health issue, those hospitalization numbers shoot up from like 7% to 23% will have a hospitalization. And even when you look at the 3 or more inpatient stays, you will see a huge increase. And these are not behavioral health inpatient stays. These are stays on Med-Surg. They may be related to a behavioral health issue, but these are not psych admissions. Okay, so what is the impact on life expectancy? If you have no psychiatric condition, typical life expectancy, this is a little bit outdated, but again, somewhere in the upper 70s. If you have a psychiatric disorder, your life expectancy drops to the mid to upper 60s. And if you have a psychiatric disorder in the public sector, meaning people that have serious mental illness, you're talking about an average lifespan of in the low 50s, a massive decrease, a huge impact. And it's a combination of factors. As you know, it is smoking, it is poor physical health care, it is lack of preventive care, it's suicide, it's a whole host of things, but clearly a huge impact on life expectancy. So the other thing that's always troubling about behavioral health care is that out of every 10 people, 6 out of 10 who need, this is 10 people who need behavioral health care, only 4 out of 10 are getting actually care, and 6 out of 10 get no care at all, which means we have a huge opportunity to reach a group of people that are getting no behavioral health treatment despite having significant symptoms. So I think this really sets the stage for the rest of the talk. So as I mentioned here, when you look at the pie of people who need mental health care. Almost 60% get no treatment at all, not from primary care, not from mental health care. So you only have about 41% of the population that needs mental health care in the US receiving care. And as you may know, the majority of people getting mental health care are getting it in medicine, not in psych. And you know this. So the general medical practice is the de facto mental health system. The majority of it is going on here, not here. So why do patients choose to get mental health treatment in primary care? So number one is cost. You know, this is a major issue. You may or may not be aware. I think most of you are. If you've ever tried to make a referral to a psychiatrist or to a behavioral health professional, what you find over and over again is that they're not taking patients. They're either full or they don't participate in insurance plans. So of all the specialties, all the medical specialties, mental health practitioners have the lowest participation rates in managed care and have the lowest rates of acceptance of third-party insurance, which makes, of course, access to specialty mental health care extremely difficult. And there's a couple of reasons for it. One is that the fees are very low, often below cost in terms of what it costs to run the practice. And two is that the rates have often not been increased in sometimes up to 15 years, still paying the same rates. And then finally, which despite parity laws at the national and state level, a psychiatric condition that is treated in a primary care office is often reimbursed better than if you treat the same condition in a mental health office, which is not the way it's supposed to be, but it continues despite laws against it. The second reason patients, of course, choose and would and sometimes prefer to be treated in primary care is stigma, as you well know. Though it is slowly improving, stigma is the number one block to patients getting mental health care. And of course, going to a primary care practitioner has less stigma, less embarrassment, and so people continue to choose primary care to get their mental health treatment because of that. The other is access, challenges to access, not just insurance, but again, for any one of you who's tried to make a referral, there are extremely long wait times to get into public mental health clinics and private practices, often weeks or even months. And most patients, of course, can't wait or shouldn't wait that long. And the reasons for that, again, are not only insurance issues and participation, but also there is a shortage of mental health professionals in the US relative to the need and demand, which means, again, that patients end up getting that care in primary care. Other issues about behavioral health care versus primary care are a significant issues around religious, cultural, and issues related to mental health care. Often hard for people to find behavioral health care if they don't speak English. There's often a lack of culturally competent services. So more often people are able to connect or find a primary care practitioner that either speaks the language or can deliver more culturally competent services. And the final issue is trust. We all know that if, many patients have a long-standing relationship with their family doctor, and because of that, they trust them. And so having a family physician tell you that, I think you may need some medication or you may be suffering from some sadness or depression is often easier for patients to accept because of that trusting relationship versus going to a psychiatrist for the first time. So that's another reason. So just to talk about the presentation of mental illness in primary care, yes, patients can come in with a chief complaint of depression or a chief complaint of anxiety, but more often than not, The complaints are more similar to what you see here, where someone comes in with stomach pains, physical aches and pains, can't get up, sleeping problems. Sometimes, people will admit that they're having a couple of glasses of wine, which turns out to be way more than that. And sometimes people will come in and talk about a loss or a stress, but oftentimes the presentation is going to be a physical symptom for a couple of reasons. One, because it doesn't carry the stigma of coming in with a mental health complaint. Two is that everybody knows that when you go to the doctor, your family doctor, primary care doctor, typically you go there with a physical complaint. So you will often get, whether it's pain, changes in appetite, fatigue, insomnia, headache, which of course can indicate a medical issue, but can just as commonly indicate a mental health condition. So the importance is to maintain some level of awareness. It is not suggesting that you assume somebody has a psychiatric condition when they come in with these, but to maintain a level of suspicion. Of course, the most common psychiatric conditions in primary care are anxiety, depression, and substance use. So those should be at the front and center of your thinking when people come in with these symptoms. Just to talk briefly about kind of what sort of some of the common symptoms are. And again, I know that nearly everyone is aware of these symptoms, but I want to point out a couple of things. So we all know that depression comes with appetite changes and weight gain changes and aches and pains and memory and concentration and sleep problems and fatigue and all of that. But the issue becomes, how do you distinguish what are often physical symptoms like appetite changes, memory problems, sleep problems, fatigue, etc.? How do you distinguish those physical versus a psychiatric condition? And the arrows are meant to highlight what we have found are significant symptoms that much more often indicate a psychiatric condition versus physical, whereas many of these can indicate a physical illness. So of course, thoughts of death or suicide is an obvious one, though patients may not admit to that. But this is a key one: no pleasure in usual activities. So I'll often ask somebody, what do you like to do for fun? It could be reading, movies, whatever. And then I ask them how they feel about doing that activity now, and they say they have no interest. That is not commonly associated with a medical problem. That is much more commonly associated with depression. So it can help you distinguish between medical and psychiatric. The other is hopeless and helpless. Now, hopelessness can sometimes, of course, be associated with somebody who has a severe chronic medical problem, but it can be helpful in distinguishing physical versus psychiatric. So keep those symptoms in mind to help you distinguish between them. The other thing is, of course, that, and we'll talk about this a little later, the incredible limitation on all of your time. One of the concerns when a patient comes into your office is, you're back to back, you have many appointments scheduled per hour. People are afraid, in a sense, to open up that question of psychological or stress or depression or anxiety for fear that a patient will sort of start to just either unravel or they will talk at great lengths, and you don't generally have that much time built into the visit. So one of the things that we recommend, and I know you may be familiar with some of these because these are very widely used tools, and in many primary care practices already being used, including in our system, but very simple tools like the PHQ-2, which can be done at the front desk before the patient even comes into your office, as you know. Just a couple of questions, which again, focus on those two things I just talked about that help distinguish depression from physical illness. So just asking these two questions and grading it, very simple, very easy. Again, can be done at the front desk or by you if you suspect depression. There is, of course, also the PHQ-9, which is a longer version, but still fairly easy to do, can be done at the front desk while the patient is waiting. And generally, we explain to patients that this is part of your overall health exam. If patients are asking kind of, why are you asking me this stuff? We just explain that this is part of your overall health. So a very simple way and quick to screen given limited time. So, you know, everybody thinks that they know how to diagnose depression because we've all received dozens and dozens of lectures on it. We've all seen it. But the data still indicates that in 2/3 of the cases, depression is missed in primary care. It's still missed. Now, it's getting better, but it's still missed often enough that we've got to, keep talking about it and be aware of it. Now, sometimes it does get diagnosed, but later on, after it's missed for a visit or two. And it's important to note that primary care providers, just like you're seeing most of the behavioral health patients, you're also prescribing 80% of the antidepressants. Two key things that I continue to see in my practice. One is I see subtherapeutic dosages in about 50% of cases, and this is consistent with the data. So people get started on an antidepressant, but they get underdosed. And then the patient gets somewhat better. And I often see these patients as being, told they're refractory, they're not getting better. And the patient will come in and say, yeah, I'm somewhat better, but I'm still not back to where I am. The most common cause is underdosing. So to be aware, to check and make sure that therapeutic dosages are being used. So on the one hand, there's undertreatment in underdosing. But the other thing I see very often that continues is that once the patient is put on an antidepressant and does better and feels better, they stay on the medicine sometimes for years and years. I see people on antidepressants 5 years, 10 years, 15 years, when they only had one episode of depression. And generally speaking, most patients, not all, can come off meds in 8 to 12 months, or at least a trial should be attempted. So just keep in mind when you see people that are on them forever and have only had one episode to consider taking them off. And the other thing that's very common is antidepressants being prescribed without a psych diagnosis. Now, some of that is due to the fact that, as you know, we use antidepressants for chronic pain and for other conditions. So that's not completely out of the question. But if you look here, over time, the prescribing of antidepressants without a psych diagnosis is growing significantly. It's about doubled from the 90s up to the about 2010. So continues to grow. So just to be aware that we are prescribing more and more antidepressants without a psych diagnosis. That may be appropriate sometimes, but it may not in others. So the other common one, again, is substance use. I'm always amazed at how we avoid and are uncomfortable with asking questions about substance abuse. Again, these things are changing and it's improving. But substance abuse is going to be one of the top 2 or 3, as you well know. And you have to ask. And as long as we ask these questions in a non-judgmental way, most patients understand. And if a patient gets offended when I ask, I explain that I ask all patients about this because it is, because it is a significant health issue. And so I'm really clear with them that I'm not just asking you. So again, just to keep in mind, patients will often admit that they're having a couple of drinks. But if they admit to that, you got to dig in. And so the questions need to include how many drinks are you having each day? And then I really like the cage questions, even though they're not as commonly used as the depression screening. But these are very helpful when in assessing whether patients have a substance use problem. One is, have you ever tried to cut down? 2 is, are people around you getting annoyed? 3 is, do you feel guilty about your drinking? And 4 is, you ever have a drink early in the morning? There's kind of a second description of the cage questions, but these questions can be very helpful in assessing and determining whether someone has an alcohol problem. Again, you've probably seen these things. I do find it very useful because it's quick. The other thing that has gotten a lot of attention that you're also aware about is suicide prevention, which, as you all know, is now a Joint Commission requirement since last year, that suicide screening has to occur in every setting: medicine, surgery, ED, psych. And there are very good reasons for it. A lot of times the Joint Commission requires things where we question the value of it. This is, in my view, not one of those things. I think this does have value. And these are the basic reasons, right? Half of patients have a medical visit within 30 days of suicide, which means that we have an opportunity to save lives if we pick up a depression or other or suicidality during one of those visits in that 30-day period. And half of those patients had no documented mental health conditions. So we want to assess everyone, not just people that have a psychiatric history. And as I mentioned, this is now required by the Joint. I'm not sure if you all have rolled that out yet across medicine and in ED, but it's coming very soon. This, I'm not going to go through this in detail, but just to tell you, this is the instrument that has been selected for suicide screening that will soon be rolled out in Med-ED, Med-Surgery, et cetera. And the purpose of this is to determine, it's just a screening tool, but it's to determine whether people are at low risk, high risk, or moderate risk, and whether that risk is acute or chronic. So for example, someone may have a history of making a suicide attempt when they were 25 years old and they're 65 now and have not done anything since. That is not as worrisome. That's sort of considered chronic risk or moderate lifetime risk. Whereas someone who has had these thoughts within the past month, which is what these questions are asking here, is obviously of great concern. If you've had thoughts or wished you were dead in the past month, and then you actually have a plan, you're going to end up in red with one of these high risk boxes. And basically what's going to be rolled out across all Med-Surg and primary care and ED is that anybody who scores high risk is going to be referred for a psych consult. And that's going to happen 24/7 in all these settings, if you know, because of the fact that we know that a significant portion of these patients are coming to medical settings, and we want to catch them and we want to provide a psychiatric consultation. So these screening tools will likely be used by nursing, for example, in the ED. And there will be a clear protocol for referring for a psych consult if that individual is deemed high risk. But this is coming to all medical, surgical, and ED settings in the very near future. Now, having said that so much is being treated in primary care now, I wanted to make sure that I provided a list of conditions that should not be treated in primary care. These are conditions that, excuse me, that should be referred to psychiatry. Anybody who has suicidality, fairly obvious. Patients who are psychotic, who have hallucinations and delusions. Symptoms that don't respond to treatment. So you have someone who has a fairly straightforward depression, you put them on antidepressants, you push up the dose, and they're just not responding, probably someone who should get referred. Anybody who has serious or chronic mental illness, schizophrenia, significant bipolar disorder. If the diagnosis is unclear, there are patients who want or need regular psychotherapy. They may be coming into your office regularly and it's clear they want to talk and they need more support. Those patients should probably be referred. Patients who have significant agitation or histories of violence, and then high utilizers, all our favorite, you know, the patients that have the many admissions and visits. Of course, high utilizers often have a behavioral health component, and psych can sometimes help with the management of those patients. So These are not hard and fast rules, but general recommendations for the types of patients that should not generally be treated in primary care. So again, I mentioned that many mental health conditions are missed. I already talked about the meds and the limitations on visits. The other thing is that many primary care providers are uncomfortable treating mental illness, and so we don't really have enough of providers there either. So just to get into sort of a couple of the other models. So I don't actually need to tell you what your typical day looks like, but I just put this up there because we all know that primary care providers and internists are facing huge patient loads, very fast-paced days, a wide range of expectations about what you're going to do and things that you're going to be able to provide to patients coming in with all kinds of conditions. The idea is, of course, to triage what's most serious, what can I do today? But the other piece that I'm going to talk about is how to get help. That involves collaborative or integrated care. Since, as I mentioned, referring to psychiatry is not always going to be straightforward and easy. So really one of the solutions is integrated care, which of course is important because we know the overlap between these three domains. Integrated care, and I'll just talk a little bit about it, produces the best outcomes. It's also less expensive, and patients actually really like it. So I'm going to talk a little bit about integrated care. So there are two ways that integrated care can happen. One is treating behavioral health in primary care settings, which is what we've started to talk about. The other is treating general medical conditions in behavioral health settings. So some of you may have heard we're building a brand new psychiatric facility on Rivington Street in Lower Manhattan, which is scheduled to open in 2 years and will be the largest private investment in a behavioral health facility in the history of New York State, a state-of-the-art psychiatric facility. And we are going to be doing primary care and specialty care inside of a behavioral health, freestanding behavioral health facility. That's this. We're not going to talk about that today. We're really going to focus continue to focus on this side of the equation. So again, there's a lot on this, but I'm going to just talk for a minute about it. There are different ways that we can collaborate in terms of providing care. One is we can just coordinate care. This is the kind of work we mostly do now, where, it's minimal collaboration, where, a primary care doc may have a brief conversation or an email with a behavioral health professional, and they kind of just communicate about how the patient's doing. It's minimal. They're not in the same location. They don't share an electronic record. And generally, it's just kind of more a referral type relationship. That's kind of minimal care, integrated care. Then there is co-located care. That would be your typical sort of multi-specialty practice, which has primary care and psych on site, right? So they're co-located, but they may be on a different floor. They may maintain their own medical records. So access to each other is easier and communication is better, but it's still like a behavioral health program inside a primary care site. So that's kind of your moderate or mid-level collaboration and integration. What we're aiming for in the future, and there are practices that have this, is fully integrated care. And the difference is, it's not just that the practices are co-located, it's that the teams actually work together on individual patients and on groups of patients. They share an electronic record, they share one treatment plan, and there's actual very close collaboration. That's the ideal. So what are the quick basics of integrated care? So first, of course, you got to train physicians in how to do it. And I'm going to talk about that in a minute. It involves generally screening of patients using things like the screening tools I just shared with you. It involves evidence-based treatments using medication and therapy, but for limited amounts of time. you're generally managing patients in the primary care practice with psychiatric support, and we track results. So just to give you an example of the continuum, which goes sort of from least intense on this end to most intense psychiatric care on this end. So if you look here, this is a person who has very mild kind of anxiety and might do yoga or listen to relaxation tapes. They're managing their mild symptoms themselves, okay? Then a person might have some slightly more significant behavioral symptoms and might see their primary care physician. They have mild anxiety, maybe some mild to moderate depression, and they go to their primary care docs. That's kind of one step up. The third step, which I'm going to talk a little more about, is where primary care and behavioral health work together, okay, in a collaborative care model. Then there is sort of the psychiatric consultant, which is your model where primary care refers to a psychiatrist and the patient goes to the psychiatrist's office. Then there is behavioral health care where we actually treat the patient for a number of weeks or months. Then there is long-term behavioral health care. And then for those that need the most intense care, they might go into an inpatient psych unit. So it's a continuum along that line. This looks busy, but it's actually not that complicated. But this is an example of the model that is most commonly used. The typical primary care practice now, the primary care provider is seeing a patient. The patient sees the, provides information to the doctor, and that's kind of where it ends. The idea of this basic collaborative care model, which is already happening throughout the Sinai health system, is that you add a case manager or a care manager who is often a social worker, and you have a consulting psychiatrist. So how does this work? Most of the less complicated behavioral health problems are treated by the primary care practitioner with no consultation from psychiatry. Again, the basic mild anxiety, insomnia, mild depression, treated just between the patient and the practitioner. If the patient has more moderate or more significant symptoms, then the care manager may get involved. And what they do is they may provide some brief psychotherapy, which the primary care provider doesn't have time to do, mostly supportive, may make a referral to a counselor. And in cases where the symptoms are more significant and the primary care provider needs some advice, that's where the consulting psychiatrist comes in and can give advice to the practitioner. They do occasionally, on limited basis, see the patient themselves, but mostly this psychiatrist is, of course, here to support the primary care provider, not to see a lot of patients directly. When they do see the patients directly, it's just a few minutes. They pop in and they leave. It is mostly to support the practitioner who is delivering the care. So that is the model that is already fairly widespread in primary care, including at Sinai. So we have a number of psychiatrists, some of you may know, Dr. Safin, Dr. Karishi, who work already in some of the primary care practices in the Sinai system. They only work a couple of hours a week providing this kind of support so that these patients that have mild to moderate symptoms can stay in primary care and be treated. So that is the goal of this model. This is the same thing, just explained differently, that you have a patient who gets educated about their condition. There's collaboration. There is primary care supported by the care manager. There is a psychiatrist available, and there is training of everybody in the model so people know when to call the psychiatrist, when not to. So just very briefly, when you employ this model of care in patients who have depression, and you look at over an 8-month period and you compare the usual care to this collaborative care, as you all know, the collaborative care consistently does substantially better, not a little better, substantially better than just usual care, where the primary care practitioner is kind of figuring it out on their own. So this model has been proven in over 60 studies to be an effective way, a very effective way to treat depression within a primary care setting. It absolutely works. And the other thing, without getting into the numbers, is that collaborative care that we just described ends up costing less, significantly less than the usual care. It saves money on just about every level of care, reduces the likelihood you'll end up on an inpatient psych unit, a medical unit, or other costs. So it is also a very cost-effective model. The other thing that's interesting is when you first roll these out, oftentimes the primary care providers, there's some resistance to it. It's going to slow me down. I don't have time to do it. People believe they're already doing a good job. But after implementation, the feedback is almost consistently positive that having the psychiatrist there and having the care manager there takes a load off. It helps speed them up. They feel like, the patients are getting better care, and it gives them time to do their work. So it's pretty universally accepted as a positive thing. And the other important part of this is that patients like it. When we talk to patients and we do patient surveys, we find that patients believe they like the access. They like the fact that the care is coordinated. They're not going to multiple sites and seeing multiple people. And many of the patients critically say that they might never have sought out mental health care if the program had not been located inside primary care. They would never have gotten any care. So it's important. And so again, mentioning that integration works, it saves money, it improves patients' lives, and it reduces healthcare costs. So just in closing to mention, this is an example of an ongoing collaborative care model. There are a bunch of them at the Mount Sinai doctors' practices. If there is interest, this group is one group that is doing that. This model exists downtown and uptown and in Midtown, actually. So if there's interest in seeing the model in action, you could absolutely visit one of these sites, and we could arrange that so that you can see kind of how the program works, or you could talk to certainly Dr. Safin or Dr. Kreshe. So I'm going to stop. It's 12:43. I'm going to stop with that and open it up to questions.
Thank you, Dr. Mitchell. This is great. We'll let people unmute themselves to ask questions or to enter them in the chat. Maybe while people are doing that, I'll just ask you a little bit about sort of from the, you mentioned all of these issues around, reimbursement that's sort of driving some of the access questions. I mean, what's sort of the next step? Like, is there stuff we should be doing on a public policy side or something to try to change that? Because I agree, it really gets in the way. We'd never tolerate that if there was some cardiologist who was only taking cash on Park Avenue.
Absolutely.
But, what should we be doing? What should we be getting into?
So I think there are a few things we are doing, and that's a great question. Thank you. So one is that I think many people may have heard the term DSRIP. So we did over the last number of years use funding from DSRIP to put these models into place. And unfortunately, a lot of that funding is winding down. But we decided, for example, with these models, that they were so effective and patients so appreciated them that we are continuing them. And the part that's hard, that's more challenging to bill for is really the psychiatric part. The medical visits can be billed. And so what Psych is doing is we are continuing to provide an hour or two of psychiatric support essentially at essentially the department's cost. So we are essentially donating our psychiatrist because we thought this program was just so important to do. And the health system is supporting us in this endeavor. The rest of it, a lot of it can be reimbursed. Some of the care coordination can be challenging. So one is advocacy around parity is a big issue, and we're doing that, which is many sort of lawsuits are pending against managed care companies to pay for this kind of service. And so I think there's that. And then there is, the other piece is advocacy around policy change to support these models, one of which is value-based payments. So since these models save healthcare dollars, as the more we move to value-based, which of course has been very slow in adoption, the more these models make sense because they actually save the system money. So that's kind of how we're getting by now.
Great. What other questions do people have?
Hi, Grant. Thank you for the talk. It's Alfred Berger.
Yes.
Fantastic talk. Clearly an area that's really in need for a lot of reasons, particularly for us to provide better holistic care to a lot of people. As you said, you wrote this book well before the 20th or 21st century, and
Yep.
people didn't heed the warnings. You touched upon it a little bit on sort of meditation, relaxation techniques, some other before you get to pharmacotherapy or even intensive, maybe one-on-one psychotherapy, cognitive therapies. How can we as general internal medicine, whether it's in the clinic or whether it's in the hospital where sometimes some of these things come out for the first time because they're in the hospital because they've ignored them for so long, how can we all better access some of these things? Is it really sort of, whether it's case managers or social workers who do licensed therapy or anything like that? How do we really enact a lot of these resources if they're not at your fingertips?
Yeah. So, that's a great question. I mean, one of the sort of great things about sort of where we are now versus back then is that there are so many resources now online that are free. So we refer, we have a list of those resources where, as you can get everything from meditation, tapes and videos, recordings from YouTube and from all kinds of sites. So we actually use a lot of that. A lot of apps now, of course, are available, many of which are free. So we use a lot of those types of things. For patients that have mild symptoms, we just suggest that they go to some of the more reputable sites. We also, again, there's also a lot of CBT, cognitive behavioral therapy workbooks, where patients can actually, again, there are tons of free sites that have those resources that patients can access for no cost, that can often help them in terms of, understanding why they're feeling and thinking the way they do. So one is to gather a list of those resources, right? So that patients can do what's there for free. The other thing that we're doing in the Rivington site and is becoming more common is that we are looking at the definition of health as being beyond traditional medical care. So at the Rivington site, we will have nutrition, exercise, yoga, spiritual care. It's all being built into the plan for providing care at that center. So some of it, I think, also involves, changing the plan, building that into your care model. And we're lucky within our system, as we have music therapy available, so we have some of these complementary therapies in the Sinai system that we can tap into in addition to the free resources. But again, I think as the payers look at us to try to reduce costs, and as we move to value-based, again, it's so slow, it's kind of frustrating, but that's when these things really pay off. Any other questions, anything about, because I get a lot of questions about high utilizers, which turn out to, as you know, they represent 10% of the patients you see, but a third of your time.
And it seems like there's a question about that in the chat.
Okay, that's a good point, because I did not actually look at the chat.
You want me to read it to you?
Yeah, I'm just trying to pull it up. Yep.
So the question.
There we go. I got it. Yes, great question. So yeah, one of the things that's happening is that we clearly do need to bring the services to those patients. And for years we used a kind of consultation liaison model of trying to do the typical behavioral health consult. That has to change. And so what we're trying to do now, of course, is more embedding of behavioral health into medical teams, and trying to do more of identifying high-risk patients at the time they come into the emergency room, not after admission. And we know there are certain patients who keep coming back to the ED. You could probably name some of them. I could name some of them. The idea there is to try to see them right at the point that they come into the ED, to try to see if we can intervene prior to getting on, even admitted to the floor. So that's how we got to, with breaking the cycle, it's really about creating a joint treatment plan. And we are always happy to work with the medical team on, like, how do we break some of the cycles? Sometimes it's about things, as you know, sometimes it's about shelter or lack of shelter that brings people into the hospital. And we do have, while no magic, we have some opportunities and access to facilitate shelter. But we also have more and more, we're using mobile mental health teams. So, people may not be aware, but we have a mobile mental health team connected to our CPEP. They can visit either virtually using phone, video, telepsychiatry, or in person. They can visit high-risk patients. And those referrals can be made from the Med-ED. And they actually are a team of professionals that can intervene in the community with high risk or high utilizers. So I can also distribute their direct phone number. They're staffed from 8 a.m. to 8 p.m. And they can go out to both an acute emergency within 2 hours of a phone call, but they can also follow up on patients you're worried about and you're trying to prevent them from coming back, where you believe they have a high behavioral health component to their illness. So that would be another option that a lot of people are not aware, that we have that team connected to our Psych ED. Any other questions in the remaining few minutes?
I mean, the other thing I would ask about is Suboxone. I think one of the most fulfilling things I've done in my primary care role is prescribing Suboxone and getting to really see it change people's lives basically in real time.
Yep.
Can you talk about how that fits in with all of this?
Yes. So that's another good question. Thank you. So just quickly, just so everyone's aware, we have an outpatient Suboxone program on the 6th floor in Bernstein. So it is available on campus. If someone needs to be detoxed, we can also start Suboxone in the hospital on our inpatient detox unit. But we do have the outpatient Suboxone program. And we also have an outpatient ambulatory detox. Patients do not have to come into an inpatient detox unit to get detoxed. We detox people on an outpatient basis, also on the 6th floor if there is a need for that. But you're absolutely right that increasingly people, especially younger people, they don't want methadone. They don't want to be tied to a clinic for the rest of their lives or for long term, and are increasingly, of course, making up the opioid epidemic, who, unlike the individuals we see at methadone programs who have typically become addicted to, to opioids and heroin from the street 20 and 30 years ago. As you know, the younger folks have been addicted to prescription pain medicines, et cetera. And they generally don't want to go to an opioid treatment program. They are much better, often willing and suited for a Suboxone program. So that is a very important tool in our armamentarium, and also available here on campus. Anything else?
All right, I think it's 12:55. We should call it a day. Thank you so much, Dr.
Okay.
Mitchell.
Appreciate the invite.
Always a pleasure. We'll talk
Thanks
to
a
you
lot.
soon. Take care, everybody.
Bye.